بسم الله الرحمن الرحيم. طلبة الماجستير طب الأطفال، السلام عليكم ورحمة الله وبركاته. اليوم معانا محاضرة Eczematous disorder in children اللي هي atopic eczema. As you see here, the learning objectives should include the concept, describe the pathophysiology of atopic dermatitis, explain the diagnosis and differential diagnosis of atopic eczema, mention complication, and describe the management of atopic dermatitis. So you see here a child on the left side unit with the cradle cup, seborrheic dermatitis, and this one also with infantile seborrheic dermatitis involving the face. Next slide. Here you see the pathogenesis of the atopic eczema. Genetic deficiency of the skin barrier function is important. The onset is usually in the first year of life. It is however uncommon in the first 2 months, unlike infantile seborrheic dermatitis, which is relatively common. Family associated atopic disorder is common, especially asthma, allergic rhinitis, and eczema itself. So, atopic eczema or eczema in general, they divided it into atopic or non-atopic depending on the IgE mediated sensitization. So IgE mediated, i.e. atopic eczema, at the onset or during the course of eczema and occur in 70-80% of patients with atopic eczema. Non-atopic is not associated with IgE mediated and is seen in only 20-30% of patients. Both forms of atopic eczema are associated with eosinophilia. Both of them, when you check the peripheral eosinophil count, it is elevated around 400 or more. Absolute count, I mean absolute count. Here you see many features of atopic eczema. Their sites of location depend on the age. So here in unit, middle of the face, and in the medial aspect of the thigh, napkin area, and lower aspect of the abdomen. When you get older, including the face, there will be on the elbow and in the popliteal region. Here in the neck, and this is the palm in older children. In adolescent or adult, may involve the palm, the popliteal region, and the elbows. Here, posterior aspect of the neck. There is some categorization depending on the severity of the lesion. So you may have a clear skin with no evidence of atopy, mild area of dry skin, infrequent itching, plus minus small area of redness, like this area, redness. Moderate area of dry skin, frequent itching here, redness, plus minus excoriation, and localized skin thickening. In severe cases, wide spread area of dry skin, incessant itching, redness, plus minus excoriation. Here is this excoriation you see here. Extensive skin thickening, bleeding, oozing, and cracking with alteration of pigmentation. Usually this area lack of some pigmentation of the skin. Around 1/3 of children with atopy will develop asthma. Exclusive breastfeeding may delay or protect against eczema in predisposition, but doesn't appear to have significant impact on the prevalence of eczema during late childhood, but definitely or at least delay the onset of eczema. It's mainly disease of childhood, and most severe and troublesome in the first year of life, resolving in 50% by 12 years of age, and by 16 years around 3/4 of cases. So the differential diagnosis of atopic eczema include the following. As you see here, chronic inflammatory skin diseases like allergic or irritant dermatitis, seborrheic in the early infancy, psoriasis like in simplex chronicus, this is chronic thickening of the skin, infectious agent like monilial infection, candida, dermatophytes, and herpes simplex virus, or bacterial like staphylococcus aureus, sarcoptes scabies, or HIV related or associated dermatitis. Neurological disorder like dermatitis herpetiformis is mainly seen in cases of celiac disease, pemphigus foliaceus, graft versus host disease, and dermatomyositis, collagen disease. Malignant disease like cutaneous cell lymphoma, mycosis fungoides, Sézary syndrome, histiocytosis X. All of them, I will show you a picture about these conditions. Congenital disorders like Netherton syndrome, Dubitz syndrome, and erythrokeratoderma, hernia varivalis. All of them are rare conditions. Immune deficiency, here it is inherited condition, X-linked recessive, Wiskott-Aldrich, immune deficiency, thymic hypoplasia, George, hyper IgE syndrome, Job syndrome, severe combined immune deficiency, and ataxia-telangiectasia. Here you have IgA deficiency. Metabolic diseases like phenylketonuria, there is eczema, resistant eczema, unless you treat the underlying cause. Tyrosinemia, histidinemia, zinc deficiency, a condition called acrodermatitis enteropathica, B6 deficiency, niacin, and multiple carboxygency, or non-allergic reaction to medication like biological factors, for example, infliximab. Here you see a picture of Netherton syndrome, should be differentiated from atopic eczema. Here there is redness and some scaly freckles on the skin and of the face and ear. Here in the back, freckling, there is redness, maculopapular erythematous rash involving the face, trunk, upper and lower limb. Here may involve the face with crustation and redness, almost erythematous burn of the face like this, and there is loss of hair. Sometimes we check a child with a chronic skin lesion that is not responding to the usual treatment, and several times they goes to the dermatologist without any benefit. So there is hair changes here, hair loss, and eczematous change with discharging ear and some lesion in the soft and hard palate. So it is a multi-system disease with aggressive system disorder. There may be associated anemia, thrombocytopenia, fever, hepatomegaly, and lymph node, which is this disease is rapidly fatal. They call it literary disease or histiocytosis X. The other collagen disease involving the skin, the musculoskeletal system, and arthritis. There is knuckle involvement here. There is redness and erythematous rash involving the hand, and there is heliotropes. This lesion vivacious pigmentation, especially here more clear, and involving the hand. High elevation of ESR, and the patient needs prednisone therapy with arthritis, of course. Here you may see a child with celiac disease may develop this lesion, dermatitis herpetiformis, form of the mucous membrane and the skin around the mouth and the extensor surface of the upper limb, I mean the forearm, and this is skin of the abdomen, this is skin of the back, the dorsum of the hand, and this is the abdomen. So this is dermatitis herpetiformis. Once you see it, you will never forget it. Next slide, here we have a parasitic lesion, scabies, sarcoptic scabi involving the web of the hand. This is the palm involvement, furrow and burrow, extremely itching disease, especially at night, and there may be another member in the family involved with this disease process. So you have to ask about the itching, especially at night, and other family members, and the involvement, pattern of involvement of the lesion, I mean in the hands and feet, abdomen, and especially genital area should also be checked for. Here you see a slide for chronic versus host disease, multi-system involvement, especially the skin of the upper trunk, the face, upper and lower limb. Definitely there is involvement of the immune cells, macrophage and other cells, lymphocyte, cause destruction of tissue, auto-destruction. So immune cell attack host tissue. This is the donor. These are the cells attacking the liver, the bowel, the skin, and other part of the body, especially in organ transplant. Here you see a child with malignancy, lymphoma, or lymphoproliferative disorder. Initial presentation, you see here there is a hair loss, and there is a skin lesion, eczematous skin lesion. So large area of alopecia with follicular plugging, loss of left eyebrow, and widespread psoriasiform plaque, especially you see here. Large asymptomatic hyperpigmented patch with numerous overlying comedone on the left chest, right in this picture. So this is a folliculotropic mycosis fungoides. Here you see a baby with Wiskott-Aldrich syndrome. I think you hear about this syndrome before. To remember the characteristic of Wiskott-Aldrich waiters, Wiskott-Aldrich, immune deficiency, thrombocytopenia, eczema, and recurrent pyogenic infection because of immune deficiency. So here see the eczematous lesion of the trunk, the face, the hands. X-linked recessive, typically IgM level are low, IgA level are elevated, and IgE may be elevated with eczematous lesion. IgG can be normal, low, or elevated, variable, but typically IgM is low. Here you may see some itchy rash, atopic dermatitis, inflamed skin worsened by rubbing and scratching. Itch is the key clinical feature in eczema at all ages, leading to an itch-scratch-itch cycle. So some diseases you see here in the clinical practice, you see in addition to atopic eczema there may be chickenpox, which is itchy rash, urticarial or allergic reaction to drugs, to foods, contact dermatitis, especially chemical substance, insect bite, popular urticaria, scabies, fungal infections, pityriasis rosea. Next slide. Here you see distribution, as I saw in previous slides, depending on the age of the child. So the diagnosis of atopic eczema is made clinically. If tested, most of the children have an elevated plasma Ig level. If there is history to suggest particular allergic cause, skin prick, radiolargosorbent assay test may be helpful. If the disease is unusually severe, atypical, or associated with unusual infection or failure to thrive, and immune deficiency disorder should be excluded, especially if there is any other association with this problem. Immunologic changes in atopic disease are probably secondary to enhanced antigenic penetration through a deficient epidermal layer. So all these should be kept in mind when you deal with a child with atopic eczema or eczematous skin lesion. Next, this is brought to you from the fifth edition of illustrated textbook of pediatrics at the previous slide. So you see here the assessment of a child with eczema, condition of the skin. You look for distribution of the lesion, skin excoriation, weeping, crustation, lichenification, and thickening. How troublesome is itching, day and night, severe, mild, worse or better than usual? What causes exacerbation, food or other allergen, irritant like soap, medication, stress, especially during exam? Does it disturb sleep? Does it interfere with life? Family knowledgeable about condition and its management. Check any evidence of infection, secondary bacterial infection or viral infection, problem from other allergic diseases, and is the child thriving well or not? How do you manage? First of all, you avoid irritant substance, especially soap, frequently using emollient, avoiding nylon and wool clothes because they induce allergy. Is there a need to give or change medication like topical steroid? Start with mild and then increase the potency of the steroid use. Immunomodulators, some medication used like calcineurin inhibitor, tacrolimus, and occlusive bandages, antibiotic or antiviral depend on the there any secondary infection, whether bacterial or viral. Antihistamine to relieve itching. Allergy test to eggs plus minus other food, especially if there is any positive test, you may avoid these foods. Is indicated to identify coexistent IgE mediated food allergy on diet elimination, or it is indicated. If so, dietitian supervision should be looked for. Need for psychosocial support. These pictures show you infected excoriated atopic eczema. Infected excoriated redness, erythema, there may be change in the blood picture and other features of inflammation. So management of this problem, avoid irritant and precipitant like soap and biological agents, emollient, moisturing and softening of the skin, always keep the child warm, topical steroid, use with care, immunomodulator above 2 years should be used, short-term topical use, tacrolimus or bimecrolimus when there is no response to steroid. Occlusive bandages may be impregnated with zinc paste or zinc and tar paste. Antibiotic antiviral, as I told you, if there is any evidence of secondary bacterial or viral infection, symptom combined with steroid, apply topically. Diet elimination, most common food allergy are to egg, cow's milk, and peanut. Elimination of these for 4 to 6 weeks is required to detect any response. Phototherapy, natural sunlight is often beneficial to patients with atopic eczema, as long as sunburn and excessive sweating are avoided. Ultraviolet A1, ultraviolet B, narrow band ultraviolet B, and fluorine plus ultraviolet A. They call PUVA therapy. Psychosocial support, because the disease is chronic and itching, interfere with daily activity, interfere with sleep, so need psychosocial support. It can be sufficiently severe to be disturbing both the child and the whole family.